So we will move on to the next topic. It's going to be a small one. So, and classification on pulmonary embolism. And we have all learned classification of pulmonary embolism in MBBS and PG. So, what is this new classification about? So this is basically from this article, which was uh, published in Annals of Emergency Medicine last year, September 2023, and it was written by Lauren Westphal and Ichi. That will be a very familiar name to some of you who listen to emergency medicine podcast because he's very famous for doing one of them. So it is a very good article, very understandable, easy language. I recommend every PG resident to read this if possible. So it mentioned the approach to a suspected pulmonary embolism. So we the approach always starts with the well score, and based on the well score, we'll divide it into low probability, intermediate probability, and high probability. And the most important thing, and the most important thing that people don't understand is that you do not do a D-dimer in low probability. If the well score is less than 2, you do not do a D-dimer. You will do something called a PER criteria. You look for the PER criteria. If all of that, if the PER criteria is absent, if all of them are absent, then nothing needs to be done. The patient is ruled out. So that is the important thing. And another thing is you do not apply the PER criteria without doing the well score. If you are doing the PER criteria right away without doing the well score, it will reduce the risk to only around 7 to 8%. Whereas if you combine both, the risk reduces to something like less than 2% or something, which is the goal when you're trying to rule out pulmonary embolism. So always combine these two: low probability, PER criteria, PER negative, ruled out. You do not do D-dimer in low probability. Why? Because D-dimer, as you all know, is notorious for a lot of false positive. Which are doing D-dimers on all low probability PE, then you will get a lot of false positive, lead to all kind of unnecessary testing and extended stay in the hospital, all kinds of nonsense. So next is intermediate probability. This is where they're actually bringing the D-dimer, and the cutoff for what you should use in your D-dimer is modified based on your years criteria. Lots of criteria have been used for this, but the one that is probably the better one is years criteria, where you look for three things. One is hypothesis, second is features of DVTs, and third is whether the B is the most likely diagnosis. If it is yes, then you use a low cutoff for DDM because the risk is pretty high. So you use the cutoff of 0.5 milligrams per liter, or you have to be careful with how the whether it is measured in mg per liter or something else. You have to be careful about that. Second, if all of these things are happened or negative, you use a higher cutoff of 1 milligram per liter. Based on that, whether a D-dimer is positive or negative, you go for CTPA. High probability, you don't mess around with the D-dimer, you go straight away with the CTPA. So again, well score, we all learned this in MBBS and PG prep. So the answer DVT and PE is the most likely diagnosis. These are the ones that get you the most points. Then that is 3 points. Then 1.5 points, you get a pulse rate of more than 100, immobilization of at least 3 days, or surgery within the past 4 weeks, or previous DVT. All of that gives 1.5 points, and hemoptysis or malignancy will give you 1 point. And you can generally you classify it as low, intermediate, or high risk based on less than 2, 2 to 6, or more than 6. Or there is another two-tier model like low and high risk based on a cutoff of 4. So that is that is how you can certify based on your well score. And if a well score is less than 2, then you go for the per group. Per group is if anything is positive, then you have to go for the D-dimer. So age more than 50, tachycardia, saturation less than 95, unilateral leg swelling, hemoptysis, recent surgery, prior PEDVT, hormone use. Don't try to buy hard this. Everything is available on MD cards. Just keep the concepts in mind. Intermediate probability, that is when your years algorithm will come into play, and the cutoff will vary based on the years is positive or negative. high probability you're straight away going for the CTPA. Pregnant patient is going to be a slight, there is going to be a slight modification of this. In that, first and foremost, you're going to go for DVT scanning. So if DVT is present, you straight away are going to go and treat the DVT, and which is going to almost be the same as the treatment of the PE anyway. And if the DVT is absent, then the next step is going to be to order the D-dimer. Again, you do a year's criteria. Here is going to be a little bit different because you already ruled out the DVT. It's going to be hemoptysis or whether the PE is going to be the most likely diagnosis. Based on again cutoff, if it is the year's criteria is present, the cutoff is 0.5. If it is not present, it's a higher cutoff of 1. And if it D-dimer is positive, then you have to go for the CTP. So that is all about the evaluation of a suspected PE patient in the emergency. Coming to the management based on the classification of severity. So this was a traditional classification of pulmonary embolism. We have low risk PE, submassive or massive. So no low risk, basically the patient is having normal vitals, no signs of RBD dysfunction, or normal cardiac biomarkers like a BNP, troponin, etc. Submassive is a patient who's normotensive, but there is evidence of RV strain on either the echo or the CT scan, or and slash or the patient is having increased cardiac biomarkers like BNP, troponin, etc. Massive is basically patients are either having patient is having a cardiac arrest needing vasopressors, or the patient is having a sustained fall in BP less than 90 for more than 15 minutes, or a fall maybe more than 40 from their baseline for more than 15 minutes. So that classifies as massive. This is the classification that we have all learned. So what is the problem with this classification is that we can almost, when we say words like massive, submassive, we often confuse the size of the pulmonary embolus with the severity. Why does this matter? Because suppose you have a young patient who's having pulmonary embolism. He or she will tolerate that embolism pretty well from a hemodynamic standpoint. They'll be symptomatic, but their vital signs will probably normal, even though they're having a pretty big embolus. Where compared with an elderly patient who's like 60, 70 years of age, less cardiac reserve, they are going to get unstable pretty quickly, even with a small embolus. So that is why this classification is really not based on the size of the embolus, it's based on what the embolus is actually doing to the patient. But even despite that, because of the way the words sound, people do confuse the two. That is why this article suggests a slightly modified classification. We have high risk PE, intermediate risk PE, low risk PE, and this intermediate risk PE is again divided into intermediate high risk and intermediate low risk. So high risk is the same thing. The patient is hemodynamically unstable, that is high risk. So with the patient, none of the other things have hemodynamic and instability. So that is clear cut. So no issues there. Low risk again, you have no hemodynamic instability, no RV dysfunction, no elevated biomarkers, etc. So this is low risk. So that is again easy. So what is this about intermediate risk? Intermediate risk, we have RV dysfunction, elevated biomarkers. If both of these are present, if you have evidence of RV dysfunction either on the echo or on the CT scan, and you have elevated biomarkers, both of them are affected, that is intermediate high risk. If only one of them is positive, that is intermediate low risk. Why does this matter? Because some of the patient in the intermediate group will require thrombolytic. And the patients who are intermediate high risk, they are probably the set of patients who are probably going to need a thrombolytic probably in the near future, even though hemodynamic instability is not present, right? So it will help. The classification, the article doesn't recommend that you straight away go to treat all of the patient with that thrombolytic, but this is something that you should keep in mind with this classification. So high risk PE stated with this patient is going to need thrombolytic the dose 100 milligram multiplies over 2 hours, or if you're doing 10 place is for it's a point 5 milligram per kg dose. So that is a weight-based dosing of 10 place. So in some peri situation, you can consider first giving a bolus around 20 milligram IV first, also followed by the rest as a 2 hour infusion. That is also something that you can try. Some patients who are higher risk of bleeding, you might consider reduce dose of thrombolytics. There is some evidence of reduced dose of the thrombolytics being safe in this in these situations also. So, and you you can you will also give anticoagulation as well, obviously with this patient, and you will generally, if you're reducing your UFH infusion, you will stop it during the thrombolysis, and you will start it shortly after the infusion is complete, based guided by your APTT. If once it returns to less than or equal to twice a norm. So basically, you can, if you're using UFS, you will so turn off the infusion during the thrombolysis, and you will restart it shortly after it's over. Basically. And basically, the anticoagulation, the anticoagulants are basically is going to prevent the further increase in the size of the clot. Whereas the thrombolytic is what will actually help you break down the already formed clot. Other things like embolectomy or catheter directed treatments are for patients who have hard contraindication for thrombolysis, or they deteriorate even after thrombolysis. And that will depend on whether you have those kind of specialists available at your particular center. Intermediate, what they recommend is that if there's intermediate high risk, you have to admit them. They need anticoagulation either with low molecular weight heparin or UFH. And if they're decompensated, you have to give them thrombolytis. You can intermediate low risk. You can actually based on other factors, you can actually consider starting them on oral anticoagulation instead of injectables. And again, they mentioned they might have to go for thrombolytis if they decompensate. Low risk PE, again, you may start them on oral anticoagulation or LMWH based on other clinical criteria that we'll also mention. The biggest headache that you'll have is what to do with subsegmental PE. That is a very small PE that we are not really sure what to do about. So if the patient is having DVT along with the subsegmental PE, you'll have to anticoagulate them. There's no confusion about that. Younger patient with subsegmental PE, no evidence of DVT, they might not actually require any kind of anticoagulation at all. But you have, if it is an elderly patient with multiple subsegmental PEs, they might actually need anticoagulation. So there is no hard and fixed guidelines for this. So it is kind of a nuanced decision making. So this precision, there are things that can help you assess the severity, like your pulmonary embolism severity index, or a simplified pulmonary embolism severity index, that your PESI or SPECI score. These will help you predict the 30-day mortality based on comorbidities and clinical presentation, etc. But there is another criteria called your HESTIA criteria. And this HESTIA criteria is specifically created to identify the patients with pulmonary embolism who can actually be discharged from your emergency department. So with your HESTIA criteria, you have all of these things. And if any one of them is present, you are not going to discharge the patient. So obviously, patient is hemodynamically unstable. You are not going to discharge them. If the patient is having high bleeding risk, GI bleed or recent surgery, you are not going to discharge them, obviously. PA diagnosed while on anticoagulation, severe pain, needing IV medication, renal failure, CKD patient, severe CKD stage 4, 5, they are not going to discharge them. Severe liver disease, basically any kind of severe comorbidities, high risk of bleeding, hemodynamic instability, you are not going to discharge the patient. So, but if you are having a low risk PE and all of these criteria are met, then you can actually discharge the patient. So the overview of all of this thing, all of this combined is that hemodynamic instability, higher risk, you'll have to thrombolize along with your heparin. Intermediate risk P, again, it will need anticoagulation. If you, there are other things that I didn't mention that you actually look for. If you have a high saddle embolus on CTP, or you have high risk features on the ECG, like RV strain pattern or new onset atrial fibrillation or something, those patients are automatically going to get admitted. No questions about that. Because those patients are going to deteriorate. And if all of these things are absent, there you don't have troponin elevation, no heart, no RV strain on the echo, then you can apply the HTA criteria. And if all of them are absent, then you can actually consider patient for oral anticoagulation and discharge from the. So that is the main overview of the pulmonary embolism as per this article. I found it very good. And if you're reading the textbook, it can be very overwhelming too, because you have all of these different classification criteria, etc. And it can all get jumbled in your mind. But this is the basic clutch things that you need to know while evaluating and treating these patients. So if anybody has any doubt, I think you can ask right now.